So what I'm going to try to talk about here is really look at pain assessment and what some of the limitations are around pain assessment, frequency of pain assessment, those kinds of things. So some general recommendations, not necessarily certainly not a requirement. I don't know that I would necessarily even say an official endorsement of one tool over another, but some general opinions about those and recommendations. And then at the end, I'm going to have some resources that can be available. What we're currently doing now is, and I'm going to get to this a little bit later in this session, is on that KentuckySOS.com website, putting together a resources tab that has these and other resources that are appropriate or applicable, maybe beneficial to various stewardship programs. So why this matters, so these are the Joint Commission Revised Pain Standards that went into effect at the beginning of last year. And you see the first one here is assessing and managing the patient's pain. The underlying part is what's new and what was added. So the old assesses and manages the patient's pain has been there through a number of iterations here. But what I think is important to get from this or to take from this is if we look at the IASP definition of pain being an unpleasant sensory and emotional experience that's associated with actual potential tissue damage. So you have the full definition thereafter, but the sensory and emotional experience, right, that there's the nociceptive response to this, but there's the emotional response as well. And this biopsychosocial approach and thought process is what's required to accurately assess somebody's pain. And the longer this goes as a more chronic problem after the acute emergent event, then the more important that emotional response to this becomes. Unfortunately, our pain assessment tools take this big complex response, right? So the sensory and the emotional experience here and try to boil it down into one number, into pick a number or draw a line on the bigger line as to where this fits. Or pick a face, or there's the other components of this as well. But we have these unidimensional pain assessment tools that have value in a couple for a couple reasons. One is that they're fairly easy to trend over time, although they're quite subjective. But they can also be very valuable in the immediate setting of someone presents immediately to the emergency department with some acute painful condition. How bad is that pain? Right, and we can assess that there. But as this continues over the course of hours to days and further on, simply picking a number or assigning a number to this is not an adequate response or an adequate capture of that entire experience that a patient is having. The other limitation here, if we take this subjective assessment and of this complex experience that boils down to one number and continually reassess over and over and over again and ask patients over and over and over again, how's your pain, how's your pain, how's your pain all the time. This is a study that was published last year that looked at the consequences of doing that. And what they identified were kind of 5 big themes or consequences from this routine, ongoing, continuous pain assessment in all patients. One of those is that it does help facilitate identification of pain in patients who might otherwise be overlooked. So people who are less likely to complain, so elderly patients, patients with dementia, patients who are nonverbal, potentially children, those kinds of things, that it's harder to capture that, or it may not be captured as readily, routinely asking can be beneficial. Unfortunately, the other 4 consequences and themes that emerge from this are not positive themes. So it likely needs to be targeted towards specific patients in context rather than every single person that comes in for every single condition. The first question and the recurring question we always ask them is, how is your pain, how is your pain, how is your pain? Because that can shift the focus away from more emergent concerns. Right? So if all we're doing and we're continually asking over and over and over again about pain, that can potentially shift that focus from something that may be more immediately pressing to the health and the well-being of the individual patient, but doesn't necessarily get that continuous attention because we're asking them constantly about their pain. Encouraging false positives. So if you ask over and over and over again, well, maybe I'm not having pain, but I don't know, they're always asking me, I guess I should say something. and could therefore prompt providers to intervene when you don't need to, when this doesn't need to be a priority, because there are, again, other more pressing things. And it engenders this kind of pain problem that you may have pain, but if you can function with that pain, then it may be okay, right? But if all we're ever asking is, well, we need to get that one number to a lower number, or to a smaller number, then that can kind of keep patients from considering alternative strategies, from coping appropriately with their pain, because they're constantly being asked, pick a number, how do we get that number lower? Well, that number's not going down because of whatever condition, then this is failing, and that has implications for coping, which then subsequently has implications for development of chronic pain and the response to acute pain. So continually asking, especially with the unidimensional scales, may have some positive consequences, but also has a number of negative consequences. So one thing that tries to address this is moving towards a functional pain assessment. So this is the clinically aligned pain assessment, or CAPA. Are any of you guys already familiar with CAPA, or already using CAPA at your institutions, or some other functional pain assessment? Okay. That's fine. We're not yet here either. So nobody in the Louisville group was either. So again, this is something to consider as we look towards things that are more functional pain assessments. One of the downsides of this is if this doesn't assign, a score, that it looks at kind of subjective answers to subjective responses, then it is a little bit more difficult to trend. And it's not quite as difficult to trend for an individual patient, but if we look in aggregate, then it becomes a little bit more difficult to trend and collect data on. But there are advantages when we look at this being used as our pain assessment tool, or as a pain assessment tool. So this divides things into 5 domains here. So the first being comfort, and the patients you ask the patients, and the patients will respond with where of these 4 categories. So this is intolerable, it's tolerable, but it's not comfortable, it's comfortable, or it's there, but I can manage it, or I don't have any pain. And then how is this changing over time? Is it getting worse? Is it about the same? Is it getting better? And then how is your pain being controlled? So what are we doing for this? Is it providing poor or inadequate pain control? It's doing okay, or maybe I'm on too many different medications for pain. But then where this really starts to differentiate itself is in these last couple of categories, because it looks at functioning as well. And that can change the way that patients will perceive this. That can change that conversation. And there's a little bit of data from Utah that I'm going to get into here in a second that supports that. And there's experiences from other university health systems across the country that would support this as well. But we look at the last 2 categories. So functioning. So you can't do anything. Versus it keeps me from doing most of the things, but I can do some things that I want to do. So one, it requires them to establish what their goals are, and then what progress are we making towards those goals. Is this keeping me from being able to do anything? So the physical pain itself may stay the same, but as coping improves and the patient can do more, then now I can do some things that I want to do, or I can do most things that I want to do. And now I can say, well, my pain seems to be getting better, as opposed to it's always staying the same because it's always a 7. Because it adds that functioning component into this also. And then how does this affect your sleep? Because we know, especially as this becomes more of a chronic condition, that pain produces anxiety. Anxiety produces a reduction in high-quality sleep. That reduction in high-quality sleep interferes with anxiety, subsequently interferes with coping skills, which worsens pain, and this vicious cycle continues over and over again. So assessing these last 2 categories of this to provide some functional component into our unidimensional pain assessment is theoretically valuable. University of Utah moved to the CAPA a few years ago, and what they actually found were their Press-Ganey scores increased from the 18th percentile up to the 90th percentile. Most patients preferred the CAPA to the numeric rating scale, or the 0 to 10 scale, which is what NRS is. And 75% of the nurses preferred CAPA to the numeric rating scale. If you guys have questions, again, if you have questions or comments throughout, I'm happy to address things. We had some discussion and things about this yesterday, so I certainly want to encourage you guys, as you have thoughts, challenges, questions, considerations, to interrupt at any time. So where we've moved, and where some other institutions have moved, including the VA, is looking at the Defense and Veterans Pain Rating Scale. So what this does is it's similar. You can trend this over time. It's not a huge culture change from the 0 to 10 scoring system with a numeric rating scale that patients are used to as well as healthcare providers are used to. But what it does is it adds a little bit of objectivity. So I don't know how well you can read these on the bottom here, but it provides objective qualifiers for what a 3 out of 10 is, or what a 7 out of 10 is, or a 10 out of 10. So it allows a little bit of kind of reframing that you go in, you wake the patient up, and they say that their pain is a 10 out of 10. Well, this isn't completely interfering with all function. You can do other things. That appears to be maybe somewhere in the neighborhood of a 3 to a 5 or something like that, right? So it can help try to get everybody on the same page between inter-patients and between providers within the same patient, getting everybody on the same page as to what an 8 is or what a 7 is and so forth. The other component of assessment is assessment of opioid-related oversedation. So this is the Passero scale. Is anybody familiar with and or using the Passero opioid sedation scale at their institution? Okay, I see a couple hands going up. So we're using it here. We're looking at how to do this in kind of a larger fashion. But what this is a 1 to 4 scoring system with scores of 3 or 4 being unacceptable, generally oversedation related to an opioid. So basically the way this works is it's either assessed at set intervals or it's assessed after an individual gets an opioid medication. When you go back in to reassess their response to that, part of that reassessment is what's their Passero score, and this goes in there. So somebody that's oversedated from this score of 3 or 4 would prompt a notification to the provider. What we've actually found here is that using this more often, so when we look at specific units that use the Passero scoring system more often, those units tend to administer naloxone for opioid-related sedation, iatrogenic opioid-related sedation, statistically significantly less often. Now that's again correlation because we look at units that do this and units that administer naloxone. That individual patient, that the more often a patient had it, is that patient less likely to get naloxone? That's a little less clear, and there's not really great data on that either. There's kind of mixed data that it changes things on the individual patient level. But certainly at the unit level, it looks like it might, because this may be a way to potentially change culture a little bit, in that there are adverse unintended consequences of these medications that we need to be aware of. So that's the assessment component. The other piece that I want to at least highlight here a little bit are what are some valuable resources, because I think that the environment has changed a lot in the past 5 years. So 5 years ago, you really have a tough time trying to find any good information about how to put together a stewardship program or how to use non-opioid analgesics or treatment resources or anything like that. That information was much harder to come by than it is now. And now we see kind of the opposite problem of there's so much information out there. How do you take all of the stuff that's available and try to distill it down into some things that are specifically going to be meaningful and impactful at your institution? And that's some of what we're trying to do online. But there's a couple I'm going to specifically highlight here. One is the description of the ALTO program. So Dr. Stanton is going to discuss the ALTO program a little bit more. He talks about the emergency department later through St. Joseph's and American College of Emergency Physicians as well. The Joint Commission Revised Pain Standards are another good place to look. Again, what we're doing here is kind of above and beyond that, but there's some descriptions of the rationale behind why is leadership involvement important, and what are they looking for within leadership involvement, if you want to take that as one specific metric. It's a little bit more detailed analysis. The CDC guidelines for chronic pain, so I'm sure you're probably aware of those in some capacity. They've gotten mixed reviews, we'll say, over the past few years. But the CDC guidelines do have, these are a series of recommendations. If you take out their 12 key recommendations, a series of recommendations, many of which apply to the ambulatory or chronic pain setting, but there are certainly some implications here for inpatient, maybe, certainly acute pain, and as we look at how that's been applied across the state with things like House Bill 333, these have been applied to subsequently look at postoperative pain in some patients also. So there's some evidence and some data with that. And then the last thing that I'll highlight quickly is the National Quality Forum, National Quality Partners Opioid Stewardship Playbook. So this is, it's a recommendation of about, I want to say it's probably about 40 or so interventions that a stewardship program could potentially make. And these are categorized into basically ease of implementation, so kind of beginner, intermediate, and advanced, as well as different categories of this involves leadership, this involves clinical care, this involves data collection, and those kinds of larger categories. There is a fee associated with that. I think it's a couple $100s or so. But that's probably, if you want to look at compendiums of information specific to opioid stewardship programs, it's one of the more robust ones that are publicly available. Brigham and Women's put out a paper that was published in the Joint Commission Journal earlier this year. I think it was January of this year. That it had some guidance about the goals of a program, metrics. We're going to talk about metrics later. It had some guidance there also. But if you look at kind of the 3 key interventions that they recommend that an opioid stewardship program undertakes, and as you look at when we discuss the standards and things later, you'll see these kinds of things coming up, as well as elements of the Joint Commission requirements coming up. But if you have opioid naive patients, as what Dr. Chang was talking about before, keep them opioid naive as much as is reasonable and as possible. So not everybody, but if you can keep them opioid naive, keep them opioid naive. And when you are using opioids, do it safely, monitor them appropriately when they are indicated, and then finally providing comprehensive and compassionate care, or at least having processes in place for referral to comprehensive and compassionate care for identified patients with an opioid use disorder. So this is what I was talking about on the KYS, or the Kentucky SOS website. So we have under the resources tab here a number of different currently active links, and we're adding to this all the time. But there's things about drug disposal resources, naloxone use, the CDC guidelines, Michigan Open, which I'll touch on a little bit later, is recommendations for post-operative opioid quantities. For selected procedures, that's updated on an ongoing basis. I think the most recent update to that was in the last few months. So this is continuously updated for a number of procedures. Some counseling guides, Data 2000, so buprenorphine waiver training, and opioid use disorder management, deprescribing references, and the ALTO program. So what I hope you got from this is when we look at assessment, in some degree, this ideally needs to capture function, or at least some component of objectivity, right, and limit the complete subjective nature of this. And then we have a lot of those resources available. I'm going to stop there. What questions, comments, anything do you guys have?
Thank you, Dr. Oyler. The question I have is partly related to an awareness that opioids, for many people, are really just a masking agent for an underlying psychosocial and even spiritual dysphoria. And we've all lived through the times when House Bill 1 came along, and we think that some of the heroin issue became available. Now people can manufacture meth. We know that there's a tide of increasing marijuana availability coming. Alex spoke to how his anxiety was really the driving factor, that when he simply discovered chemicals that helped deal with his anxiety. What I'm hoping we can do is have just as compelling an argument that while we are looking to avoid opioids exposing to people that are feeling an improvement of some underlying issue of the type I just mentioned, that we look for ways to deal with that appropriately and not just leave them bare and spare for lack of opioids. And I think if we don't fill that gap with something more wholesome, that we know patients' tendencies to simply gravitate to something else they can get their hands on and can afford. And so that's simply an argument I hope we keep in mind. Sure,
yeah. I would definitely agree that if you don't have some source of meaning, then you tend toward whatever is the easiest thing in life. And many times that can become some kind of ultimate substance use disorder that masks some underlying condition. So certainly, I would agree with you that treatment, comprehensive treatment of substance use disorders, comprehensive treatment of mental health conditions is incredibly important, addressing social determinants of health that impact this. So there's a lot of there's a lot of things. I think Alex mentioned somewhere, kind of perfect storm that kind of came together to create specifically the opioid crisis. But I mean, there's a larger problem within society as a whole, and I would agree with you there. I think kind of where we came from in this light specifically, keeping those points in mind, is looking at the role that the healthcare system has played in creating and sustaining the current problem, to what degree we have, and how can we, at bare minimum, stop contributing to it as much to the same degree, but certainly keeping in mind, and as this grows and continues, then keeping in mind and addressing the underlying social environment that contributes to this. Because I would also agree that I think, or maybe you didn't mention this, I don't know that agree is the right term, but that within especially smaller communities, the hospitals and the health systems are pillars of that community and are potentially well equipped to address a number of other things as well. But where we're kind of coming from here, starting smaller, if you will, at least minimize our continued contribution to the problem. But those points are well taken. Other questions, comments, or thoughts?
Going back to the assessment tools and the alternative tools, if you will, that seem to be getting some attention, do you have even an informal prediction of whether we're going to move to a different standard?
So I'm hearing some yeses from are you speaking for the Joint Commission as you speak for that? I'll let you talk to it.
Yeah, I think we're going to talk about it in the data section. So one of the things that we did when we looked at the metrics, and I'll preview it a little bit. If you think about opioid stewardship, people in the room with me right now can probably think of 80, 120 metrics that we would all like to track, right? And in fact, at UK, we track about 33 of them. But some are subjective, some are not quantifiable, and therefore difficult to report. Some are challenging for certain hospitals. Like I could say the number of pills dispensed after an elective hip replacement. Well, not every hospital in Kentucky does hip replacement, so keep that in mind when you think about it. But to answer your question, the thing that we do keep in mind is try to anticipate where CMS is going to go. They've said it. It's not like we're reading their minds. It's just when they publish it, it's hundreds of pages. So Doug's read it for us. We believe there are a couple of metrics that CMS is going to tackle, and obviously I don't have a way of knowing whether it's going to be put into effect and whether it's going to be a bonus point system or is it going to be like a hack penalty where they reduce your CMS payment by 1% or whatever. That's all possible. But what I will say is we do have that in mind, and that we believe that if we do this will save your institution time down the road, so we're not scrambling when it does come into effect, and we would already be a year or two ahead of CMS. So that's my comment.
Yeah, I think so. I think to the point of specifically, are the pain standards from Joint Commission going to change to recommend a function-based assessment? That I don't know. I think where they stand now is this is something you should assess, and the current language of you should assess this allows for institutions to move towards a function-based assessment without being in direct contrast or being in any contrast to the Joint Commission standards. So I don't know that I would say that I would expect them to move and adjust their standards to say this assessment tool needs to be multidimensional, needs to capture function, something like that, because there's still some value in certain environments to the unidimensional tools. But I think the way that they are now are at least open enough that allow institutions to move towards this. in addition to the points that Dr. Chang made about CMS and others.
I just had one comment, and I'll talk loud on it. When we're talking about data collection and metrics, all that's very important, I know, to work with quality in the hospital. But I think at the same time, when we're implementing these tools, that we need to be very careful about not forgetting the patient and being more concerned about meeting the metrics as opposed to what happens to the patient. Because I've seen this happen personally with my husband, who's been in the hospital over 200 days in the last 3.5 years. And a lot of his care was not patient-focused. It was making sure that those hospital was meeting those metrics. So they kind of forgot about him, but they were making their metrics. And I just think that's something important, that we still need to stay patient-focused.
I would agree. And that was part of the impetus for having someone like Alex as part of the advisory board for this as a patient within the healthcare system, to help keep that as a clear point of emphasis, that we are looking to stay patient focused in this as well. But that's another really good point. Thank you.